preparing for a new child. But for this 47-year-old patient, the growing abdomen brought an entirely different reality. Instead of celebrations, she was faced with hospital visits, diagnostic tests for a disease that had been silently progressing for months. We present the case of patient VD, a 47-year-old female who came in due to generalized abdominal pain. Upon physical examination, she was noted to have soft, tender, and enlarged abdomen with an abdominal girth of 114 cm. 1 year before admissions, the patient first noted gradual abdominal enlargement, initially presenting as a lump without associated symptoms. Over the succeeding months, the enlargement progressively increased until it reached the level of the umbilicus. When the salient features stated, several etiologies were considered, including pregnancy-related causes, systemic condition, infectious processes, and neoplasms. 2 months before admission, the abdominal enlargement became associated with pain. Pregnancy-related causes were initially suspected. However, the 1-year progression was inconsistent with its timeline. Further evaluation revealed bilateral renal parenchymal disease with consideration of complicated ascites. Systemic and inflammatory conditions such as liver cirrhosis, nephrotic syndrome, and endometriosis were then entertained. However, these became less likely since the patient has absence of chronic liver disease, generalized edema, and dysmenorrhea. Subsequent imaging demonstrated a possible ovarian U-growth in which malignancy could not be totally ruled out. At this point, infectious processes seemed less likely since the patient did not exhibit the constitutional symptoms. Gradually, the clinical picture shifted away from an infectious process towards a possible neoplastic condition. However, just as the differential diagnosis seemed to be narrowing, one important possibility forced us to pause: peritoneal tuberculosis. Despite the absence of classic symptoms, peritoneal TB is well known for mimicking ovarian malignancy, often presenting with progressive abdominal enlargement, ascites, and abdominal pain. Currently, the possibility of a neoplastic process became increasingly concerning. Given these findings, the leading differentials were as follows: primary peritoneal carcinomatosis, ovarian tumor, and peritoneal tuberculosis mimicking ovarian carcinoma. With the remaining differentials still overlapping clinically, we shift our perspective from the bedside to the laboratory, as if viewing the case through a microscope. Laboratory evaluation showed low hemoglobin and hematocrit with elevated WBC and platelet counts. Blood chemistry further demonstrated elevated LDH with significantly elevated CA125 levels. These pertinent findings significantly align with the 3 differential diagnosis. Now looking at the lab results, the patient shows difference in areas of the labs where peritoneal tuberculosis would not show normal levels, such as these. Despite the laboratory findings, primary peritoneal carcinomatosis and ovarian malignancy continue to share the remarkably similar features, making the definitive distinction difficult. We therefore shift our perspective once more through the eyes of a surgeon. And finally, the distinction became clear. Primary peritoneal carcinomatosis and ovarian malignancy may appear nearly identical, but in our patient, an additional crucial finding was identified: a new ovarian mass. This became the turning point in our case, strongly favoring an ovarian origin. These operative findings now allow us to understand the disease process at a deeper level. The patient begins with a normal surface epithelium with which repeated ovulation leads to increased disruption and repair. This was the beginning of her history of a benign ovarian cyst in 2009. However, despite prior treatments, a metachronous growth later developed in the contralateral ovary. At the molecular level, the earliest driver is KRAS mutation, activating the RAS-MAPK signaling pathway, leading to multiple processes that results in a slow, indolent tumor growth. ultimately supporting the diagnosis of low-grade ovarian serous carcinoma. Eventually, the tumor cells disseminate through the transcelomic spread into the peritoneal cavity. These implants release inflammatory mediators and VEGF, which increase vascular permeability, ultimately producing ascites. Multiple processes then work together for which the patient had developed pain, thrombocytosis, anemia, elevated LDH, and elevated CA125 levels. On tissue examination, the following microscopic features are expected. Compared to high-grade, low-grade serous carcinoma demonstrates a slower growth due to the absence of TP53 mutations. Microscopically, the tumor forms the following features. Taken everything together, we are now led to the final diagnosis of Type 1 low-grade serous ovarian carcinoma, FIGO stage 3. The management followed a multi-model approach. Primary cytoreductive surgery was done in order to remove as much tumor burden as possible, followed by a platinum-based chemotherapy. Hormonal and targeted therapies may be utilized for the maintenance and long-term disease control. Continued surveillance with CA125 monitoring and clinical follow-up is essential to detect recurrence and maintain the quality of life. What once resembled a sign of malignancy, what once resembled a sign of new beginnings, ultimately covered a silent ovarian malignancy, reminding us that sometimes the disease whispers long before the disease begins to scream, and it is our duty to listen. Thank you very much for listening.